Clinical examination of an abdominal lump. For inspection, let the patient lie down supine, relaxed with the legs semi-flexed. Expose the abdomen from the level of the nipples to the groins. First note the contour of the abdomen. Is it scaphoid, normal or distended? To inspect the contour, imagine a line from the tip of the xiphoid process to the pubic symphysis as demonstrated by this ruler. If the abdomen is concave and lies below this line, it is termed as scaphoid. If it is more or less along this plane, it is flat or normal. And if it is above this plane and convex, it is termed as distended or protuberant. If the abdomen is distended, note whether the distension is uniform or is it more in one area or to one side. For this, compare the symmetrical areas on both sides of the midline for fullness. Inspect the lateral borders of the flanks, whether they are distended or concave. Note the distended right flank compared to the normal left flank which is concave. And later, in sitting position, we will inspect the renal angles for fullness. Note the renal angle fullness on the right side in this case of a right renal lump. Now inspect the skin over the abdomen for redness, scars, striae, branding marks, nodules and dilated veins. Redness over a lump suggests local inflammation. Redness of skin around the umbilicus in an acute abdomen suggests acute hemorrhagic pancreatitis, termed as the Cullen's sign. Branding marks usually suggest presence of chronic or long-standing pain. Hard subcutaneous nodules, as seen in this case of carcinoma of stomach, indicate secondary spread of the malignancy to the skin. Dilated veins around the umbilicus with centrifugal flow suggest portal hypertension with caput medusae, while vertical femoroaxillary veins are seen in vena cava obstruction. If there is a scar of previous operation, ask the details about the nature of the previous operation. The scar itself will tell us many things. For example, this scar at the McBurney's point is of appendicectomy. This scar under the right costal margin is of cholecystectomy. This scar is of suprapubic cystolithotomy or prostatectomy. This scar is of a kidney operation. Now note the widening of this scar in the central part. A ragged wide scar suggests wound infection after the previous operation. After inspecting the skin, inspect the umbilicus. Is the umbilicus in the center? Normally, it is in the midline, midway between the tip of the xiphoid process and the top of the symphysis pubis. It is displaced upwards by the lumps arising from the pelvis. Note here that the distance between the xiphoid process and the umbilicus is less than the distance between the umbilicus and symphysis pubis. In ascites, reverse is the case. The distance between the xiphoid process and the umbilicus is more than the distance between the umbilicus and symphysis pubis. This is Taniol's sign. Then note the shape of the umbilicus. In ascites, it may be transversely stretched, or a laughing umbilicus, or everted as an umbilical hernia. Then ask the patient to cough and look for an expansile impulse indicating an umbilical or paraumbilical hernia. Now inspect the abdomen tangentially from the side and from the leg end for the movement of the abdominal wall during respiration and for visible peristalsis and visible pulsations. Note the abdominal wall movement during respiration and compare it with the chest expansion. If thoracic movements are more prominent, it is thoraco-abdominal breathing, common in males. If abdominal movements are more prominent, it is termed as abdominothoracic type of breathing, more common in females. In peritonitis, as seen in this case, the abdomen does not move during respiration. Note that only the chest expands. In localized peritonitis, only the affected portion of the abdomen may be immobile. If there is a visible lump, particularly if it is in the upper abdomen, observe carefully whether it moves up and down with each respiration. Note the movement of this lump with respiration. Now this is a liver with multiple nodules. Note the movement with respiration. The lumps connected to the diaphragm, that is from liver, gallbladder, spleen and stomach, move very well with respiration. Renal lumps move slightly, while retroperitoneal lumps and intra-abdominal lumps not connected to the diaphragm do not move with respiration. Then look for visible peristalsis. Note this peristaltic wave in the epigastrium moving from left to right. This is a characteristic sign of pyloric stenosis. These are visible peristalsis in the distended coils of small intestine in intestinal obstruction. And this is a stepladder pattern of peristalsis showing multiple distended loops rising towards the center, typical of low ileal obstruction. Lastly, look for visible pulsations. Aneurysm of abdominal aorta, as seen in this patient, is pulsatile. If a lump is in the epigastrium or umbilical region, that is overlying the abdominal aorta, it may show transmitted pulsations from the abdominal aorta. The lump itself is not pulsatile. These pulsations will disappear in the knee-elbow position when the lump falls away from the aorta. You should also keep in mind that in a very thin patient, even the pulsations of the abdominal aorta may be visible. Having completed the inspection of the abdomen proper, ask the patient to stand and inspect the scrotum for a testicular swelling. Note the epigastric lump due to secondaries in the para-aortic lymph nodes arising from a right testicular tumor. Then inspect the hernial orifices. Ask the patient to cough and look for a cough impulse. If the lump is arising from the pelvis or is very large, inspect the legs for edema. Then ask the patient to sit and, standing behind the patient, inspect the spine for any deformity, gibbus, kyphus, kyphosis or scoliosis. Inspect the paraspinal area for any paraspinal swelling or sinus. Paraspinal sinus or scar is very suggestive of tuberculosis of spine. Then inspect the renal angles for fullness. Note the fullness of renal angle on the right side, in this case of a right renal lump. Lastly, inspect the left supraclavicular region for a swelling due to enlarged lymph nodes. Left supraclavicular lymph nodes can be enlarged due to secondary deposits from the malignancy of stomach, colon or testis, termed as the Troisier sign. And the enlarged left supraclavicular lymph nodes are termed as the Furcow's nodes. This completes the inspection. Remember to inspect the 4 sides out of the abdomen: scrotum, hernial orifices, spine and the left supraclavicular lymph nodes. To revise, on inspection, note the contour of the abdomen, whether scaphoid, normal or distended. Look for a localized bulge, and if localized bulge is seen, note the effect of raising the neck. Inspect the skin for redness, scars, striae, branding marks and dilated veins. Inspect the umbilicus for position, transverse stretching or eversion. Observe the movements of the abdominal wall and movements of the lump with respiration. Look for visible peristalsis and visible pulsations in the lump. Ask the patient to stand and inspect the hernial orifices and the scrotum. From the back side, inspect the spine, paraspinal regions and the renal angles. And lastly, inspect the left supraclavicular region for swelling. Now let us proceed to palpation. For palpation, the patient should lie comfortably and relaxed on the examination couch with a pillow under the head and legs semi-flexed, preferably with a pillow under the knees to relax the abdominal wall muscles. Ask the patient to take deep breath through open mouth. If your hands are cold, especially in the cold weather or after washing the hands with cold water. Warm them by rubbing against each other before commencing palpation. First, note the temperature over the site of the abdominal lump, comparing it with normal, and note if there is any local rise of temperature suggestive of acute inflammation in the lump. Then palpate gently with a flat hand all over the abdomen to feel the tone of the abdominal wall muscles and tenderness. Normally, the abdomen feels soft and elastic and is non-tender. If there is tenderness, that is pain on palpation, demarcate the exact area or point of tenderness. For example, this patient has localized tenderness over McBurney's point, suggestive of acute appendicitis. Then note the presence of guarding and rigidity. If, as you press over the abdomen, the wall muscles contract and the wall becomes firm and non-elastic, the reflex phenomenon is termed as guarding. Note the soft abdomen on the left side and the reflex muscle contractions or guarding on the right side. If the muscles are in a state of sustained contraction, even when you are not palpating, it is termed as rigidity. Note the board-like rigidity all over the abdomen in this patient with acute peritonitis. If guarding is detected, keep the hand over the site with gentle pressure and divert the patient's attention to some conversation. Observe whether the guarding disappears. Voluntary guarding, which is due to patient's oversensitivity or fear, will disappear if you successfully divert the patient's attention away from the act of palpation. If there is mild localized tenderness, look for rebound tenderness. Palpate the tender area with a flat hand and slowly press down the hand, pressing deeper with each expiration. Now withdraw the hand suddenly. If the patient gets acute pain on withdrawal of the hand, it is termed as rebound tenderness. It indicates inflammation of the parietal peritoneum due to underlying inflamed organ. Note the acute pain on withdrawal of the palpating hand. In presence of intestinal obstruction, rebound tenderness suggests strangulation. Now let us proceed to deep palpation. This includes a detailed palpation of the lump first and then palpation of the rest of the abdomen. Palpation of the lump. Before proceeding to the detailed palpation of the lump, first you must determine whether the lump is intra-abdominal or extra-abdominal. For this, first feel the swelling, keep your hand at the lower border of the swelling and ask the patient to take deep breaths. If the swelling moves with respiration, it is definitely intra-abdominal. If it does not move, it may be either parietal or intra-abdominal. Then ask the patient to raise the neck, making the abdominal muscles taut. If, on raising the neck, the swelling becomes difficult to feel and less prominent, then it is intra-abdominal. If it becomes more prominent and easier to palpate, check whether it can be moved side to side. If it is mobile, as seen in this swelling over the right hypochondrium, then it is subcutaneous, superficial to the muscle. And if it becomes fixed on contracting the wall muscles, as seen in this patient, then it is within the muscle or intramuscular. If the lump is situated laterally